Hi, it's Dr. Sandy Laura Cremers. Thank you for joining us today on podcast number 14 of the EYE show. I have my very special guest, Dr. Alberto Martinez, who we've been friends and colleagues for now 9 years. Can you believe it's gone so fast?
Wow, time's gone fast.
Time's gone fast. So when I first came here from Boston, I won't say the word Harvard, I came into this office and I've told many of you I was so impressed by what Dr. Martinez has built. I'm very impressed with his pterygium surgery, which as ophthalmologists is kind of the bread and butter of kind of surgery in general. For most people, when they're training, learn to do surgery on pterygium, and then you go on to do cataract surgery and intraocular surgery. But doing a good pterygium is very, very tricky because the risk is that it can regrow. And you've seen multiple complications around the world of people that do a part, don't do a great job, the pterygium comes back. And we're going to talk about what all that is, what the treatments are, and go from there. So first, tell me what a pterygium is.
Well, a pterygium is really a disease of mostly poor people, and this is why perhaps it's not as well paid attention by the high institutions.
But you've had surfers from Australia, California,
Well, it actually can grow. I have librarians from Maryland with this disease, so it's a disease that is generally associated with sun exposure.
That's right.
And usually the people who get exposed to the sun are people, of course, in the equatorial zones of the world. So it's mostly Africans, equatorial Africans, Central and South Americans, and people from the southern parts of the United States, Florida and California. This is why we call it surfer's eye, because it was in the United States is known initially because the surfers get it because the sun and the sand, and what it is damage to the surface of the eye caused by ultraviolet radiation. When the sun hits the eye, this is a model of the eye. Of course, the only part exposed is the part in between the eyelids. In fact, maybe I should use your eye rather than this eye. This is my pointer. When the sun gets the eye gets exposed to the sun, the parts that gets most exposed is this little white part, the temporal because it's close to the temple, and the nasal part because it's close to the nose. This white part of the eye gets exposed, and of course the cornea. The cornea has amazing defense mechanisms. The cornea is so important to our eyes that the cornea doesn't really develop that much sun damage. But the white parts of the eyes, as the sun comes in, especially the sun that comes from the sides, it focuses in this area of the eye, and the continuous exposure of the sun, we don't really know exactly what is it that causes. It's still a mystery. That's one of the reasons I love the disease, because it's a mystery. Is that the cells that are at the border between the white part of the eye, the sclera, the conjunctiva, and the cornea, those cells get damaged to their DNA. And so they start growing. So what you do is you have this tissue that these cells that are supposed to stop here and allow the cornea to be transparent. These cells are damaged and they start growing over the cornea. So you have this tissue growth over the cornea. Now it can be anywhere from just a very small amount, a millimeter of tissue, to a tissue that grows all over the cornea. So you can see how if tissue grows completely over the cornea, it can be a blinded disease. And there are some populations in the planet where pterygium is a blinded disease. So for example, the Eskimos, who get exposed, they have double exposure to the sun, right? The first from there and the bouncing off the ice, and they have no eye care, no access to eye care. Those people, you have something called kissing pterygiums, a pterygium coming from the nasal part and a pterygium coming from the temporal part, and they close and they can cause blindness. But at the least they will cause astigmatism. They cause the cornea to be distorted, and they cause visual loss. In reality, most of the time, pterygium is really partially a cosmetic disease and partially something that bothers you. Because what happens is when you have a growth in there, as the eyelid goes up and down, it kind of bumps against this elevation that shouldn't be there, So patients reported a foreign body sensation when they blink, and especially if they have dry eyes, they have something bothers them. So it's not a severe pain, but it's something bothers them. And in addition to that, especially for younger people, and especially for women, it's this redness, this fleshy area. It looks cosmetically objectionable. The eyes are so important for your cosmesis.
So the symptoms are redness, pain, sometimes foreign body sensation, irritation, dryness, itching. Those are the key things that can be the symptoms of it. And then if you look at the eye, you can often see it. So many people have a pinguecula versus a pterygium. So what's the difference between a pinguecula and pterygium?
It's very simple. The pinguecula is that it's a very weird name. It's a Latin-based name. And so, but what happens when the damage is only confined to the area, to the white area, the sclera, when the damage is confined there, it's called a pinguecula. And a pinguecula is just simply a precursor to the pterygium. Once that continuous damage happens and the pinguecula invades the cornea, once it invaded, it's called a pterygium.
It crosses the limbus, right? So you would say crosses the limbus, then that's the definition.
Exactly.
And pterygium means wing-like, and it can be used to refer to any abnormality anywhere in the body. So there are pterygium of the toes and pterygium of the knees and things like that. But this is, we're talking about of the eye. And so we used to think it was just a cosmetic issue. But then we published a paper in 2016 with Jenny Ha, Dr. Jenny Ha, who showed that the invasion of the actual epithelial cells go further into the cornea. And it was one of the first papers to kind of show an objective measure of the severity of the pterygium, which was a very quiet paper, but it was published in one of the best journals in ophthalmology, Journal of Cataract and Refractive Surgery. So it kind of goes to the issue of trying to do research in this very common malady, but trying to understand what defines mild versus severe. And then the other thing is we've been talking about this, and we've been noticing, and we're hoping to publish this research sometime soon, is that if someone has a severe pterygium, it seems like that chronic inflammation is destroying the glands kind of in that area. So this is a myography that I'm showing patients on the YouTube video of what the gland should look like of each eyelid. We all have these glands that look like vertical white columns under a special camera called the myography. And we need each gland to produce oil. But with pterygium, what I've been noticing, and I think you've also noticed it, is if there's a lot of kind of inflammation in the nose, those glands tend to disappear and atrophy faster than the other. That's what I've noticed.
In reality, we are not exactly sure
which came first.
Where those glands are damaged by the pterygium, or people that have damage in that area preferentially have more likely to have
Very
pterygium.
good point. Yes.
As I said, pterygium is a mysterious disease, and we are doing research on that. It's a passion of ours. We have patients from all over the planet that come for this disease because we have focused on this disease, and we really have world-class expertise on that. You know that.
So tell me about your treatment, and how has it evolved from when you were a resident to now?
Well, it's a disease of the humble people.
Okay.
I trained at the University of Texas San Antonio, and it was a disease of the humble. And we would do it at the end of the surgery, and we take the tissue out and close the wound, and
that was it.
It looks great.
No beta radiation.
No, it looks great,
Okay.
and then we leave, and then the recurrence rate, they come back worse than before, up to 50% of the time.
That was just if you cut it and close. That's all you would do. Okay.
It's insane. So now we start doing all kinds of other things. So people, because it comes back, and this is something that has been documented since Egyptian times, because it comes back. Some people start doing radiation, better radiation, strontium-98, better radiation. So they would irradiate, supposedly very gently, the area so it doesn't come back. That was a disaster because it caused all kinds of other problems,
like
unintended problems, cataracts,
scleral melt.
Exactly.
So
that's out of favor. And then what some people started doing is start removing the tissue. So when you remove the conjunctiva, it leaves the bare sclera. You could put amniotic membrane, and that's what a lot of people do because it's very convenient. Amniotic membrane is just a layer of the placenta that is against the uterus, and it has a special healing properties that I'm pretty sure you've talked about.
We've talked about, yep.
And so you put it there, and it does reduce the recurrence rate to maybe 5%, but cosmetically it doesn't look as beautiful. So over the years, for me, it has evolved that where what I first do, I remove the pterygium, and then I go to a part of the eye that is virgin, usually under the upper eyelid, that has never been exposed, never exposed to the sun.
I never had surgery before.
And create a beautiful, very detailed, very exact, with measurements, a graft that we put over the area. We used to suture it, and the problem with the sutures is that it causes a lot of foreign body sensation. A lot of people, it was painful, it was very difficult, it was time consuming, and so about 15 years ago, we discovered the glue, which had been used in other areas of the body.
So fibrin glue.
The fibrin glue, which is a product of the blood. And so we glue that graft in place, and that makes it so our recurrence rates, when I started doing surgery, it was about 10%, with the best way I could do, 10%. It has been going down to the point where we get one recurrence in 200, 0.05%. It's a really, really low recurrence rate. But what we do now, besides removing these and putting the graft in there, on top of that, we put an amniotic membrane. We don't do just amniotic membrane and nothing else. We do a graft, and on top of the graft, the amniotic membrane, and that does two things. One, the recurrence rate is almost negligible, but two, the cosmetics outcomes are beautiful because the amniotic membrane has these healing properties, these anti-scarring properties. We don't understand exactly how it works, but we have our cosmetic outcomes are fantastic.
Are beautiful, absolutely.
And, but we always are pushing the envelope in other areas. You know, one of the things that we always have done, well, not always, but in the last 20 years, as I've learned, we never cauterize, because when you cut there's little blood vessels. Most people take those little blood vessels and zing them with a little heat, but that's traumatic, and it causes inflammation, and inflammation causes recurrence. Another thing that I had argued with my colleagues about is the little part of the cornea where the tissue was, they just kind of maybe sort of clean it up with a blade
the limbus
at the cornea.
At the cornea,
But we take a diamond burr and beautifully polish the cornea, make it perfect surface, so that there's less scarring and it's likely to recur. And on. As you know, we are continuously sort of figuring out new ways, better ways of doing these procedures.
You know, I've seen your surgery, it's absolutely beautiful. So just to kind of recap, the pterygium is a growth of abnormal cells. So the eye has the window of the eye called the cornea, the white part is the sclera, and the sclera has this clear tissue called the conjunctiva. And so that conjunctiva is growing over the cornea in an abnormal way due to UV light. And we've also talked about how these cells invade the cornea and can leave a scar on the cornea. So you were the first person to ever teach me how to do corneal tattoo, which is very interesting because it is something that not many people know about. And so when there is a white kind of scar on the cornea that's left over, some patients in the past said, didn't you get rid of the, the growth? Why is it still there? And it isn't still there, it's gone, but the scar tissue remains. So Dr. Martinez used corneal tattoo, how to kind of cover that white scar to make it look like the normal iris color. So explain how you do that.
Well, actually, it's not very complex. The cornea is transparent, right? It has to be transparent to allow the light to go through. And the pterygium, when it grows over the cornea, when you remove it, it can leave a little bit of a white spot, and people find that objectionable. So what we do is we clean that area and put ink. These are special inks, very special inks, microfilized, just very special inks. And I used to take a needle and drive that ink into the corneal stroma. Now what we do is we have a regular tattoo machine. It was just little needles go very fast up and down, and you have 1 or 3 needles, and we take, so it's a lot faster, a lot easier. We put the ink, and with a little machine goes, and we paint that area of the same color as the iris. So if that area, if the patient has a blue eye, we paint the area blue to match the color. So when you look at it,
Nobody can
You-
tell
you
unless you're under a
can't tell.
microscope,
You
right?
have to look at the microscope.
Mhm.
So it's a very simple thing.
Mhm.
It's done with just drops as
Mhm.
anesthesia, and very effective.
Yeah, it's very effective.
simple.
It is
Yeah.
amazing. It's
Mhm.
it's quite helpful
Mhm.
for a lot of conditions, not just
Yeah.
pterygium scars, but you've
Mhm.
even used it for other kind of, I know, post LPIs. I think you've done it in a couple of patients where a patient had a laser procedure for something unrelated to a pterygium, where there's a little hole in the iris and there's a little extra glare. And so I've seen you kind of cover that, which helps some patients so they don't need to have a major intraocular surgery, which has been great. Now the other thing
It's also
yep.
also used. You know, the cornea for any reason is white,
Mhm.
and it's very cosmetically objectionable. And we have a lot of diseases of the eye in which the eye has been damaged so much it doesn't see, and the cornea is white.
Mhm.
You can sort of tattoo the entire cornea of the color of the other eye, same.
mhm.
So at conversational distance,
Mhm.
nobody will know
That's
that
right,
your
yeah.
cornea was white. So
Mhm.
it's also a beautiful, a very elegant cosmetic procedure. It's a lot safer for changing the color of your eye than doing some of the surgeries that people go to other countries
Right,
to get
that's
done.
right. Yep,
Mhm.
very good. And then the other thing that we've all used that do pterygium surgery is something called Mitomycin C,
Mhm.
which is a kind of chemical that we use on the surface of the eye to help reduce risk. So tell me how you've used Mitomycin C in the past, and do you still use it?
Well, Mitomycin C is something called a radiomimetic drug. It's a drug that mimics radiation, so it sort of prevents, it disrupts the DNA and it prevents growth of scarring. And in some patients that have a high chance of recurrence, especially the temporal pterygiums, or a patient, I get 10% of the population that I do surgery on, people have had pterygium surgery elsewhere and they recurred. So when they come back, I know these patients are at high risk. So I remove the pterygium and then I soak these little sponges with this medicine in a liquid form and place it there for 2 minutes, and that radiomimetics, like radiation, very gentle radiation, prevents the scarring, reduces the amount of scarring, so it reduces the amount of recurrence. It's a very important drug, it's a very serious drug. I use it very judiciously. You have to be very careful because you have to clean the eye very well, irrigate it, and you have to be careful because it's a strong drug, it's a cancer drug. So yes, we use it judiciously, especially in recurrence.
But it doesn't cause cancer on the eye if you use
No,
it.
no,
It's just
no,
you
no.
mean to say that it's
No.
it's kind of a anti-metabolite.
It's used to treat
And
cancer.
it's used,
We
right.
use Mitomycin C. That some of these exposure to the sun can cause people to have cancer. There's something called squamous cell carcinoma. So if you keep exposing the eye to radiation, you get cancer. When we remove those cancers, we use Mitomycin C because it is a cancer to treat the cancer. It's a medicine that is used for cancer treatment.
And so what's the risk with Mitomycin C?
Well, I think the risk is if you use it and you don't cover the sclera with conjunctiva, it can get an avascular area. The blood vessels don't grow in there, so the area gets exposed permanently and it can start melting. And that has happened. So you never want to use that medicine without putting the 2 layers that we usually use. The people who get into trouble with mitomycin is the people who use it with the bare sclera, and we know that some people do that. We have seen the papers and the cases in the literature.
Great.
So
what do you think is the next frontier for pterygium surgery?
well, we know that, right? What we know is that the next frontier is harvesting a few stem cells from the conjunctiva, growing that in a petri dish in the laboratory, having the little tissue, and then once we remove that, use that patch to grow, to put it there, and then rather than glue, maybe just some very special dissolvable staples that will cause that. So, but that does is it prevents us from having to harvest tissue
The
from a
superior
different
conjunctiva,
part,
that's right.
different
Yep.
part of the eye. It's a matter of time. Of course, ultimately, we like to find out what is it that caused these, and maybe a magic drop that would prevent this damage from happening, and so it would never happen.
Or sunglasses.
Idea.
People don't like to wear sunglasses.
It's kind of a challenge. It's more and more just getting kids to wear glasses.
Yeah.
Unless, it catches on in Instagram or something like that.
Right, exactly. Any other comments about pterygiums? Because you've done more pterygiums than any other person I know in the world.
I don't know anybody who's done more, or
I
that's
don't
more
know
than
anybody.
I do. I did like, I don't know, so many, 15. I do more in one day than people that do in a year.
That's true.
But I think the reason is, honestly, for me, is I think it was my destiny. God wanted me to, because I've had pterygiums in both of my eyes. I have surgery in both of my eyes. I've done surgery in my father and 3 sisters. And so, and it's a disease that I love, that I have so much respect, so much interest on. And I think it's a disease that we do very well on, and we take care of. It's very interesting. But for the audience, the important thing is wear sunglasses.
Yes, of course. And then the
Wear
last thing I
sunglasses.
want to mention is that you do the surgery in your office, which is very special, because at Mass Eye and Ear, in most places, it's in the operating room in a hospital or a surgery center, and that can be really stressful for patients. It's a kind of big day that you have to feel like you're going into surgery, and there's all these nurses and everything's kind of scary and a lot of noise and doctor noises and things. But doing it in the office, I think, is very more relaxing for patients. Very safe. We've had some data that we're trying to publish on the safety of doing it in-house. We call it in the office because it's more comfortable for the patient. And I think the risks of infection, you've had probably 0 infections in your entire life.
Never had an
It's
infection,
very
which
right.
is
It's
unusual.
incredibly rare to
That's
have an
because
infection with
it's
this.
a very vascular. You know, it's again history. This is a disease of humble people. So way back in the day when I started doing it, a lot of Latinos, a lot of people had no insurance. So if I would take him to the operating room, it was hugely expensive. We need an anesthesiologist, operating room, and a surgeon. That's 3 different charges. So I started doing it in the office, and over the years we developed this amazing ability to do them in the office. I've done 10-year-old kids.
Yeah.
And so we can do anybody. It's very safe. The pain score is so low in a scale of 0 to 10, 10 being the highest pain, and 0 being no pain. Our average pain score is 2. So most people have no
Yes.
pain. It's a 15-minute procedure. You come, we do it, put a patch, you go home. While most of my colleagues, they take the patient to the operating room. They start an IV, the IV sedation, so they can give anesthesia. It's a very elaborate, hugely expensive. Over the years, I've saved the insurance companies millions
I
and
believe
millions
that,
of
yeah.
dollars in all those fees that we don't use.
And not to mention the IV is a 10 out of 10 for a lot of people,
Right.
in terms of pain.
And-
Just the IV
but
itself.
not only save all that money, not only
Mm-hmm.
must save, but I really don't know. I really don't know anybody who has a lower recurrence rate than I do. So we are unique in that
I
area.
agree. Yeah, I
in the
agree.
world,
It's
you
been
know.
an honor to learn from you, because we as surgeons, you kind of gravitate to the cataract surgery, of course, as eye surgeons. But doing a really good pterygium is not easy. And I think it's been very helpful to watch over the years, refine your technique and see your patients, and it really is beautiful surgery. And it makes a big difference, because what you see when you see a patient is their conjunctiva. You notice it. You don't notice the implant in their cataract. You notice it. So it's kind of an important disease. Anything else you want to comment on, or?
No, I think the frontier also is cosmetic. The ideal procedure, you as an ophthalmologist will look at it and you say, I don't see anything.
You can't even tell, right?
No surgery ever done.
Yeah.
The eye looks beautiful and
Yeah.
perfect. That's something.
That
so
is something. Absolutely
very,
great.
very blessed. I feel very blessed to be able to have done these and to do so many and
Great.
and to do it well.
Thank you, Dr. Martinez. Thanks for being with us on our
You're
podcast.
welcome.
Thank you, everybody, and please subscribe to our podcast. Please share it with friends and family. And thank you for all your comments. Please keep sending them in. Thanks to my team behind the scenes, George and Katya. Thank you.